Hello and welcome to this session of CareMap updates for the February 13th, 2024 CareMap updates. So with this here, we're just going to start off with our first CareMap of Emergency Response Service work scope. So basically there are going to be some minor changes to our actual scope of work, and we're going to cover those right now. First one's a note here is underneath our medication guidelines of what we can and can't do. One of them ones is in regards to insulin, in regards to diphenhydramine or Benadryl, and tetracaine. All three of these medications are being taken away from our scope of work. We are not going to be carrying them on the ambulance anymore. So Benadryl and tetracaine are not to be used on the ambulance. And realistically, insulin wasn't really being used in the field anyways, so that is being taken out of the formulary of medications that we can give with standing orders. Other things that have been changed here are deep pharyngeal suctioning, nasal packing for epistaxis, needle decompression for cardiac arrest, tooth reimplantation and wound repair with tissue adhesive, and vaccine administration during a public health emergency. These have all been removed as well. We just found that these weren't really anything people are doing in the field, and the vaccination administration isn't really a big concern as much as it was during the height of the COVID pandemic. Other things as well of note here is under the medication administration by procedure and route, inhalation with nebulizer has a new addition of footnote G, as you can see in the corner there. So with this one here, it says the new addition is to emphasize that paramedics are not to nebulize patients older than the age of 5. So if you want to nebulize a patient that's in their 40s with salbutamol nebulizer, it's still recommended to use an MDI because it's just been shown in studies to be more effective. We're only going to be nebulizing either epinephrine or salbutamol for children 5 and under. And that's really updates for the work scope CareMap. We're not making too many drastic changes here. The next one we're going to look at is high alert medications. So this is a newer one here. So with high alert medications, it's basically going to be how we labeled our medications now. So these require additional safeguards, including independent double check, specific storage instructions, labeling requirements to enhance patient safety, and also basically to reduce errors that may lead to the possibility of serious harm to our patients. The Shared Health Provincial Clinical Standard has been developed to promote the safe prescribing, labeling, packaging, storage, preparation, administration, and monitoring of these medications. So in this CareMap itself here, it has Appendix A. So this includes the medications on the provincial high alert medication list that are used by EMS during primary response and interfacility transfers. So I'm not going to go through the whole list. It's in the new CareMap when it's released on the website. But basically showing what we have in the field. So what we're actually allowed to do based on what we have in our ambulances, and also what we can take as a high alert medication on IFTs. And these are more commonly placed ones. So on the CareMaps here to recognize a high alert medication in a medication formula, for just example here, I have epinephrine for cardiac arrest. If you look at the actual document itself, up in the upper right corner, it has a high alert medication red box. I'm sure you've probably seen these before already. So with this here, it's saying that this medication has to be, certain precautions have to be taken when using these medications. So one of the things we have to be careful of is an independent double check. That's mandatory. So with these medications, we're going to confirm with our partner dose, med, date, all that good stuff. Make sure it's not expired, it's the right concentration, especially when it comes to epinephrine. And we need to actually check with our partners, not just say, does that sound good? The partner needs to do their own check as well, and we need to confirm that everything is good to go. So with that, we also want to double check our calculations. So with that, it has to be visual. It's like, okay, this is the concentration of med I have. This is the dose as per the CareMap. And ideally, your partner should be double checking your math and double checking the CareMaps to make sure that it's safe to give. The paramedic who will be administering the high alert medication must be one of the two individuals to perform the independent double check. So obviously the person giving it should be one of the people involved in checking it. And if the paramedic's working alone, they must perform a self-check when preparing and administering high alert medication. So mentally, I get it. If you're going emergent in an ambulance, your partner's driving, you're by yourself in the back. Individually, you need to look at, okay, this is the right medication, this is the right concentration, I've recalculated my dose, and this is okay for me to give this medication. So during the medication preparation, the double check or self-check must include the following. So like I mentioned this already, and this is straight out the notes in the CareMap, this is all in there. So the correct medication and concentration, the correct volume of medication if needed, and the correct type of, and type and volume of diluent, if applicable, and the correct volume and concentration of the finished preparation. So for example, when we dilute morphine, it's 10 milligrams per 1 ml. And then once it's diluted, it's 1 milligram per ml. So we want to make sure that it's the right concentration and with the right diluent as well, because we should be mixing with saline. Now, remember, when we're mixing these medications, we don't use our preloads. They're just for flushing IV starts. They are not for mixing in medication. That is from the manufacturer of our preload saline syringes. They're just for flushing lines. So with that, we also want to make sure, like if we're doing our 100 cc bags with our TXA, that we have the right concentration, right drip rates, things like that, if we're doing any kind of infusion with a high alert medication. Okay, so once we get our infusion set up, we also need to have the drug name, dose, concentration, volume on the bag. I'm sure lots of people have seen these in the hospital when they have the actual labels and they put them on the bags. So we need to do that as well. So patient's name, initials of both paramedics. That way we can confirm that 2 people have confirmed the infusion rate, the dosage, and the fluids, and the time, concentration, and the patient's name as well. During medication administration, the double check or self-check must include. So this is when we're giving it, and these are a lot of the rights of medications: right patient, right med, right concentration, right dose, right route, and right time if applicable. So nice thing in Disney EMS, usually the correct time is now. So, but when we also look at doing things like infusions or slow pushes, giving medications over 5 to 10 minutes, we have to make sure that we're not giving them too fast, and that is part of the thing we need to consider when we talk about correct time. In addition, double check or self-check of all intermittent continuous infusions must also include the correct rate. Again, we got to make sure we're checking our infusion rates. I get when we don't have a pump, when we drive down the highway, as soon as we hit a bump, we get like 20 extra drips, but we should be aware of that as well and just keep an eye on it to make sure the patients may not be getting their medication infused too fast. If we do have a pump, we need to make sure we have the correct pump settings, and that if it's an IFT, we need to confirm that with the sending staff before we leave the facility to make sure that we have the correct infusion rate and the correct administration set, especially when we're correcting our, figuring out our own drip rates. Are we using a 10 or 15 drip set? And that can change our infusion rates. So we would need to make sure that we're aware of that as well. And that's high alert medications. The next update here is the aerosol generating medical procedures. So with this here, it's just kind of reviewing again what we're looking at, what we need to use extended PPE, what we don't need to use extended PPE for. So the first one here is prohibited procedures. So obviously these ones we're not supposed to be doing. And there's been quite a few changes in the terminology in this care map here. So now it's if the patient has known or suspected COVID, we are not to do CPAP ventilation, and we're not to give positive pressure ventilation without a sealed airway. So if you want to ventilate these patients, they have to have an iGel in place. So now a patient will be considered to have or possibly have COVID infection if they've tested positive in the preceding 10 days by self or lab tests, or if their status unknown, but COVID is reasonably suspected based on the patient's clinical presentation or known exposure. So if they're living in a house, everybody else has COVID, they've got COVID-like symptoms, you got to kind of figure they probably have COVID. Okay. So with that, we also have our list of permitted procedures with extended PPE only. So with that, for young children who may not cooperate with meter dose inhaler administration, the risk of aerosolized generation is likely lower with nebulizer administration. But even then, like I talked about with 5 years of age, you still need to wear your extended PPE. So again, when we talk about extended PPE, we're talking about mask, goggles, or safety glasses, gloves, gown, all that good stuff there. So these are all the lists here. So intranasal sublingual medication, epinephrine by nebulizer for croup, salbutamol nebulizer, like I was talking about. Neonatal resuscitation, including PPV without a sealed airway. Placement of maintenance of blind airway. So basically what we're looking at is basically anything that's to do with the airway. We also do not perform CPAP or positive pressure ventilation without first sealing the airway to a patient with known or suspected COVID infection. And also with this as well, it says CPAP ventilations excluding known suspected COVID. So we are allowed to use CPAP here, but we should be using, as long as we're not considering they might have COVID or we got a high suspicion for COVID. Again, same thing with ventilation. If that's the case, we shouldn't be doing this, but if we are going to do it and we're not really suspecting COVID, we should still be wearing extended PPE. Big thing is as well, though, if we are doing CPAP on a patient, we're kind of like, maybe I'm not sure. For CPAP, you really should be kind of sure before using CPAP. But if you're coming into a patient with a patient that you suspect has COVID, and you're ventilating them without an I-gel, then you should be definitely giving the receiving hospital staff prior notice to arrival so they can wear appropriate PPE as well. So things that are permitted, so without the use of extended PPE. With that, we've got chest compressions, defibrillation, cardioversion, transcutaneous pacing, and just giving oxygen at nasal cannula, non-rebreathe, whatever you need to do. So during CPR, airway manipulation is the main source of generation for aerosols. So when it comes to defibrillation chest compressions, they're not really considered significant causes of aerosol production. So CPR may potentially be required during transport. Paramedics should not extend a PPE prior to transporting because now you're in a confined space. You're not in an open space like in a house or anything like that. If oxygen is being delivered, ideally we should be covering the patient's mouth and nose with procedure mask over top of the oxygen delivery equipment. So if they got a nasal cannula, non-rebreathe, we put our procedure mask over top of those devices. That way the patient's still getting that 100% oxygen, but we're protected from whatever they're blowing out. And that's the update to aerosol generating medical procedures. So this care map here is who to call. So there has been a lot of confusion about what's going on in regards to who do we call for what. So this is a new care map. It's replacing A02 on who do we call when we need assistance. So with that, we have one for trauma support. A paramedic will contact the Medical Transportation Coordinator Center, or MTCC, and request online support for any of the following. So with that, we have trauma support. A paramedic will contact MTCC and request online trauma support. Okay, so it's not online medical support anymore. It's online trauma support for the following. So require authorization for EMR or PCP to discontinue resuscitation of a traumatic cardiac arrest, or destination direction for transporting a traumatic cardiac patient with ROSC, or if transporting without ROSC. Okay, so we are going to be calling, it's not online medical, it's online trauma support now. So we're also going to call them if it's authorization to bypass for patient meeting major trauma bypass criteria. So again, when we're going for trauma team activation, we're going to be contacting dispatch and asking for OLTS, or online trauma support, not online medical support anymore. And delegation to various standing medication order for major trauma patients only. So obviously anything traumatic, we're talking online trauma support as opposed to online medical support. So for medical support, we're still sticking with online medical support. So with that, we're going to call dispatch and ask for OLMS. Versus trauma, it's OLTS. So we're going to contact online medical for required authorization to discontinue resuscitation. That's for EMR and PCP. To discontinue resuscitation of pediatric patient, that's for all levels. You need to make that phone call first. And delegation of standing medication order. So either you need to give more, less, different dosages, or you just have a question about whether it's safe to give a medication. If you have a direction to care map specifically directs to contact online medical, for example, all of our obstetrical care maps all strongly urge that you call online medical, especially in neonatal resuscitation. A minor patient is refusing treatment or transport without an adult custodian present or available as per A05 treatment transport refusal. A patient or their proxy is requesting transport to a specific destination for medical reasons without a documented pre-approved destination for this patient. So as per care map B01 standard destination. And a hospital reduces emergency department services. So again, if they shut down because they don't have enough staff, doctors, nurses, they're overwhelmed, however they decide to redirect, B02 redirection advisory states that we can call online medical support for assistance with figuring out where to take our patient. And before the interfacility transport of a patient in labor, so D01.2 labor IFT, before we take any patient in active labor, we are to call online medical for direction to ensure that it's safe for us to transport that patient. And as soon as possible, all pre-hospital deliveries, newborn resuscitations, and like I said before, all the obstetrical emergencies in section D strongly recommend calling online medical. So paramedic may contact dispatch to contact online trauma support or online medical support at any time for clinical or decision destination direction, advice, or support. Again, they're kind of a backup. So again, if it's anything trauma related, you want to call for online trauma support. If it's anything medical, or as per care maps, it says to call online medical, we're going to ask for online medical support. Okay. So other people we're going to call. So if it's a code STEMI, And so we've done our 12/15 leads on our patients. It's turned out that it says STEMI on the ZOL. We're going to contact dispatch and we're going to request the name of the co-STEMI physician on the call and then contact them directly as per E04. If it's for an acute stroke, for a patient who has an acute stroke and meets the criteria to transport to the stroke center, we're going to contact HSC paging. The phone number, as you can see there, is in the big yellow box in the care map itself. And you're going to request to speak to the stroke neurologist for a stroke 25 outside call. So for an LVAD patient, so with that, we're going to call St. Boniface Hospital. So we're going to call them through the paging operator. The phone number again is in a nice yellow box right in the care map, and request to speak to the VAD, or the LVAD coordinator on call as per care map C08. We're going to talk to them anytime we have an LVAD patient. We should be calling them. And that's who to call. So again, it's a bit of a synopsis of if we have these conditions, who's the best person to call. That's what this care map is here for, to kind of direct paramedics on who to call when you need assistance. Another one that's new here, so this isn't really new, it's just been some updates. So who can give orders? So standing orders and delegations. It's been kind of reformatted here. So with this, we have section A, so that's your ERS physicians. So with that, an ERS medication document is a standing order from the ERS medical directors. It enables a paramedic to administer medication under a specified set of conditions. So basically what that means is we have our M documents and we can just go ahead and do it. We don't need to call to get permission to give a medication every single time we need to give a med. But if you do want to give a medication in a different capacity, like we're kind of talking about the who to call, we need to contact online medical or online trauma, because again, if you need to give more pain control, for example, above what the max is, you need to phone, because if the patient's doing well on it, but it's not working as well as it could, like as long as it could, and you might want to increase the dose, we don't have a standing order. The other thing as well, when we look at standing orders, is a lot of our medication standing orders start at 12 months or 1 year of age and up. So if we have a patient that's younger than 1, we're going to have to call and get direction for dosing because we don't have standing orders. That means the physician has to get involved. So when it comes to that, you can, as a paramedic, you can accept an order for online medical support, online trauma support, the medical director, associate medical director, or the ERS chief medical officer. But when you do this, when you ask for this, it has to comply within your scope of practice and competency, and is to only be used for that one patient. So if you do a patient and you ask to give extra amounts of morphine or fentanyl, and the doc's like, yeah, absolutely, go ahead. And then your next patient comes along, it's reset. You can't say, well, the last patient I was allowed to give extra fentanyl, so now this patient I'm going to give more as well. It's a one-time, one-patient delegation. You can't take it with you. So ERS affiliated physicians here. So some of the physicians that can give us direction, STARS or Life Flight Transport physician. Okay, the WFPS medical director, associate medical director, the code STEMI physician for STEMIs only. So obviously we're not going to be calling this STEMI physician for trauma bypass, things like that. So, but if it is STEMI related, example, give it our cardiac medications, we can take direction from the STEMI physician for those. The stroke neurologist for a stroke patient, obviously if we call the stroke neurologist and we look for redirect and therapy options, we're going to take their advice. And of course, if we're contacting the LVAD coordinator, we can take direction from the LVAD cardiologist. So one big thing to keep in mind is that there's an LVAD coordinator and there's an LVAD cardiologist. So the LVAD coordinator is usually a nurse. We can't take delegations from them. But if the LVAD cardiologist is on the phone, we can take orders of procedures, or again, as long as it applies within your scope of work or practice, we can take direction from the LVAD cardiologist. Okay, and again, like I said before, these delegations are one time. So for IFTs, for clinical care that might be reasonably anticipated to be required during an IFT is not already covered by care map or medication document, a written order must be obtained from the referring physician. So again, if they have a specific medication that this patient needs at certain times, we need to have a written order. So that could just be we have their just medication profile from the hospital, or we have specific medication direction from the hospital, but it has to be written and signed by the physician saying that we can do it. And this, again, also has to comply within your scope of competency. Okay, so if they're asking you to do medication or route you're not comfortable with, or it's just outside your scope of practice, you can't do it, then you have to make sure they're aware of that. Okay, and you have to have a copy of the order attached to your PCR. You can't just say see notes and then hand in your PCR and there's no notes with it. We need to have that written documentation attached to the PCR. So whether you have to make a copy because one has to stay at the hospital or whatever, you need to have one with your PCR, especially if you're going outside your regular scope. Okay. If it's very time sensitive, like say your patient starts seizing all of a sudden, or they're in a critical unanticipated situation, the delegation can be given verbally. So when you're doing an IFT, ideally call the sending facility because they have a better understanding of who their patient is and what their conditions are. And they may be able to give you delegations to medications that online medical may not because they don't understand the regular ongoing of that patient. So try to call the sending facility first if you need immediate delegation for that patient. And a big thing is make sure you document the PCR, the physician you talk to, the time you talk to them, the orders they gave you, document all that stuff. Because again, if we don't have a written order, we have to make sure we have some kind of contact to know that you just didn't do it on your own. If there's a doctor on scene, so section D, on-scene physician. So an individual on scene who self-identifies the physician may be able to provide expertise and experience to assist with life-saving care. So with that, they're not allowed to give you delegations to deviate from approved care maps or medication standing orders. So if you're going to give your 50 mics of fentanyl and the doc's like, nah, give this guy 200, he needs it. We are going to say no because that is outside of our max there. We can't do that for per dose. So with that, they can't just tell us to start giving random doses of medications. You are, however, may accept an order from an on-scene physician if there is not a medication profile care map that covers the situation. And the paramedic reasonably believes the person is a healthcare practitioner, and you can absolutely ask for their identification. Like anybody can come up on scene and say, I'm a doctor. So if you're not sure, even though they're spouting a lot of good medical terms and stuff at you and they make a lot of sense, just you can ask for their qualifications. There's nothing wrong with that. Okay. The big thing is, though, is that if they're going to be doing anything above your scope, you need to make sure that they're aware that if they have to stay with that patient once they start working above the paramedic attending scope. Okay, so you have to tell them that if we're leaving, you're coming with us now as well. So section E for delegations here. So basically this is just a kind of catch-all. So an EMR cannot accept any delegation beyond the user's scope of work, even with a physician's order. Okay. PCP or an ICP cannot accept a delegation from a superintendent or supervisor. So if you call OCS to give this patient more medication, they are not permitted to give you that authorization. And like I mentioned before, the LVAD nurse coordinator cannot give you special orders. It has to come from the cardiologist and a non-prescribing provider, so a nurse or a CT technician. So if a patient's acting up in the CT department and the CT tech asks you to sedate them with midazolam just because they're being awkward, we can't take orders from them. That's not a thing. Okay. And we can't give each other standing orders. So ideally that we can't just say, you know what, give this guy 10 times the dose. We can't just do that to each other in the back of an ambulance. It has to come from somewhere higher medically trained. So obviously like online medical. And that's who can give orders. So another one here is adrenal crisis. So with this one here, the big difference is really, there's not too many big differences here, but the difference with this care map with the update is that how we administer hydrocortisone. So with that, in the notes here under 4, it says now that we can administer hydrocortisone by the most expedient route possible. So it used to be just IVIO, but now we can now give this medication through IM. It was determined that the max dose when we give it when we give the hydrocortisone dose, it maxes out at 1 ml. So that is totally safe to give in the deltoid. So we can give this medication IM as well. That's adrenal crisis. So basically it's just we have a new route to give it. Other things as well. So we have asthma, COPD, acute decompensated heart failure, respiratory stress of unknown cause. I kind of lump these all in together because the changes are the same in all of these care maps. So with that, it's new addition to the notes in all of the above care maps for asthma, COPD care. So with that, we have it all here. It talks about what we can do during patients that might have COVID. So CPAP ventilation can be performed if the patient has tested negative that day or the patient status is unknown, but COVID is reasonably not suspected based on circumstances leading up to the event. So like I was talking about before, we're not really, they've got no contact with patients in the home. They haven't had any COVID-like symptoms until this happened. So especially their acute decompensated heart failure patients, if all of a sudden they start getting flash pulmonary edema because something happened, zero COVID concerns, like none of the fever, aches, chills, loss of sense of taste, we can safely give it. We do not perform CPAP if the patient has tested positive for COVID in the preceding 10 days, or the patient has had a known exposure, or COVID is suspected based on the patient's clinical presentation, like I discussed earlier when we talked about the different procedures. So that narrative has just been added into the care map just as an update of when it's safe to use CPAP or not. So with this one here, so E16, so this is the new palliative care map. The early palliative care map was for when it was still a pilot project. It's no longer a pilot project. It has been deemed as we're going to continue doing this program within the East Zone only at this time. So what it is instead of making a pilot project, they made it an official care map, and it is E16. So some new updates to this. So in the care map itself, it now states in order for paramedics to access this care map, the patient must not only be enrolled in the IRHA palliative care program, but paramedics must have successfully completed the palliative LEAP training program within the East Zone. So unfortunately, if you have a truck from south or west that comes into our zone, one, can't do this care map because it's East Zone, and two, if they don't have their LEAP paramedic course, they can't provide the palliative care with this care map either. So in the former care map, ketamine could be given intranasal. This has been removed, and now ketamine is only to be given by a subcut line or IV if we ever get ketamine back. For these patients, we are no longer giving it intranasally. Another thing as well is fentanyl. It's just been updated to show that PCPs can give fentanyl by any route just to match the medication profiles. And there's been a change in regard to airway secretions. So in the old care map, as you can see here, it says airway secretions, yes. It says PCPs and up, we could use scopolamine patches. So scopolamine patches, as I'm sure many people noticed, we don't have them on the truck anymore. They're no longer available, and we just can't get access to them. We were hoping that we could find a different supplier, but that is not an option at all. So with that, we have taken it out. So in the new updated care map, airway secretions have been removed due to the patches no longer available, and like they were minimally used when we did have them. So we didn't see the point of replacing it with something else with higher level of medication that would require training for all of our paramedics. So we actually just removed it out of the care map. So for airway secretions, if it is an issue with your palliative care patient at end of life, we're just going to go with non-pharmacological therapies. So again, maybe positioning or just education and emotional support for the family to explain to them what is going on, what that sound is. It's just fluid buildup. And again, suctioning doesn't work because it's lower down the airway. So maybe just possibly moving the patient so it's not so loud and doesn't bother the family as much. So at the bottom here as well, in the final box in the care map, it used to say, if goals of care do not include transport, support on scene until issue resolved. Otherwise, transport to closest ED as advised. So with this box here, there's been an update to that. It's been made change. So now it says in the final box of the care map, it says, if goals of care do not include transport, support on scene until resolved. Otherwise, transport to closest ED or advised. Now it says, if time on scene will exceed 60 minutes, consider online medical. So when we look at the former one here, it just said, just hang out on scene until you got things done here. Now, if you're going to be sitting more than an hour, maybe consider calling online medical. Okay. Also, if patients confirm direct admission to palliative care bed, bypass ED and direct transport direct to palliative care unit. So with that, if they have a destination based on, they actually have the paperwork saying that this is where this patient's to go if anything comes up, they're to go to this facility, then we can take them to that facility. We don't have to take them to the closest hospital every single time. Okay. And that's the updates to the palliative care map. Again, it's not E30A anymore. It is going to be replaced with E16. So it's no longer a pilot program. We did a really great job in our zone of making this program happen. So now it's become an actual care map. And in the E zone, we're going to continue providing this care to our palliative care patients. And that is it for these care map updates. There's still more updates in other videos, but thank you for watching this one. And if you have any questions, feel free to call me at emseducation@irha.ca. Thank you.